of diabetes with DKD should be on SGLT2 inhibitors, and lpshita doesn't require any introduction. She is a very well-known endocrinologist in Kolkata, Howrah, everywhere.
Thank you, ma'am, and it's always a pleasure to be in HDS, and this is a lovely platform to talk about few new things, and some things are actually not taken care of in regular conferences. So these are some important nuances that needs to be talked about. Thank you, ma'am, for this lovely introduction of mine. Should all patients with type 2 diabetes be on SGLT2 inhibitor by default? So in this case, I'll be talking about the prevalence and the etiology of diabetic CKD or a CKD, for instance, how frequently we find a diabetic patient having CKD, and then I'll be talking about the mechanism of action in which SGLT2 inhibitor acts in diabetic CKD. Then I'll be talking about the importance of early screening and intervening in patients of CKD, and what are the guideline recommendations for those. And then I'll be reviewing the clinical trial data that we have in hand and the reasons, the indications to use an SGLT2 inhibitor. So if you look into a multicentric study from India, where we have seen that around 62.3% patients having CKD are diabetic. So that is very important. The rise in the number of patients which is globally found to that number which is found in India is significantly higher. And if you look into the comorbidities, diabetic CKD with obesity was found in 55% patients, whereas diabetic CKD with hypertension was found in 78%, which was far more than non-diabetic CKD. So comorbidities were more. So if you look into the etiology of CKD, we find that around 58% patient of CKD has diabetes as a comorbidity. But if you look into that 58% of patients with diabetes and CKD, we'll get to know that 86% has diabetic CKD. The reason for that CKD is diabetes. So a huge percentage of the CKD population has DKD actually. So if you look into these stages, first we have the renal hypertrophy, then we have the incipient, then overt diabetic nephropathy, and then the ESRD. And with that, along with that, the structural changes that occurs, which is an increase in the kidney and the glomerular size, then the GBM thickness, which further on increases, and then we have the sclerosis, inflammation, and fibrosis. We have a decline in the eGFR and an increase in the albuminuria, along with an increase in the pressure as well with the time span as it goes by. So if you look into a healthy kidney and if you look into a diabetic kidney disease, what we see is with an increased glucose load, we have an increased infiltration of the leukocyte. There is an increase in the afferent vasodilatation along with podocyte loss, mesangial cell thickening, glomerulus thickening. Then we have the tubulointerstitial damage. So more or less each and every part of the kidney is damaged because of this increased glucose load. And in the next slide, if you look into a diabetic kidney patient getting an SGLT2 inhibitor, we see that the amount of inflammation goes down, the ischemic injury, the hypoxia goes down, and we have an increased erythropoiesis. Along with the solute reduction, we have an improvement in the glomerular capillary pressure. We have a reversal of all the hypertrophies that is going on. So there is also an improvement in the mesenchymal transition in the proximal tubules as well. So in gist, if I have to talk about, first, it improves SGLT2 inhibitor, improves the vasodilatation, the afferent arterial vasodilatation. Along with that, the glomerular hyperfiltration. Along with that, an improvement in the hypoxia, improvement in the inflammation, and most importantly, improvement in the sympathetic nervous system activity, which in turn is shown to have an improvement in the eGFR level, improvement in the BP, improvement in erythropoiesis, so there is an improvement in the ischemic injury, and along with that, a tubular glomerular injury is also improved. So in short, we have weight loss because of the calorie loss that happens with glucosuria. It's a non-hypoglycemic agent, so hypoglycemia is a rarity with an SGLT2 inhibitor. Thirdly, it reduces the blood pressure. It's a uricosuric drug, so it reduces the uric acids as well, and it reverses or reversibly lessens the eGFR. Now, what is CKD? CKD is a condition in which, a chronic condition in which it actually requires 3 months for diagnosis. It's a structural and functional changes which happens to the kidneys, which affects the quality of life in an individual. The eGFR has to be less than 60 and or an A2 or A3 albuminuria. We need both albuminuria or a urine ACR and an eGFR for a risk stratification, because risk stratification is both of them are individually important, because it is individually related to cardiac events and a kidney event significantly. And what we need to know as well, that in a patient with no CKD and a patient with any form of CKD, the cost or the hospital admission increases by 4 times, and if the CKD stage is 4 or 5, it increases by 12 times, which is a massive burden for us. So how to screen, when to screen, and how frequently to screen, and whom to screen. Any patient with type 2 diabetes coming to us, we need to screen at the very beginning. And in a patient with type 1 diabetes, we have to screen every 5 years, at least after 5 years, sorry. And we have to do that annually. And what we need to do is both creatinine eGFR and urine ACR, both are equally important. This is the typical change that happens in an eGFR after the use of an SGLT2 inhibitor. And the thing that I have mentioned, that the sympathetic nervous system activity is reduced with the initial natriuresis. What we find is by the end of 14 days, we see an improvement in the non-epinephrine level with the use of an SGLT2 inhibitor. So this is a typical prototype patient, a diabetic middle-aged patient with a 5 years history of diabetes, hypertension and dyslipidemia. And we are having in this patient a background retinopathy with frequent episodes of hypoglycemia. If you look into the HbA1c, it's only 7%. The patient is on non-hypoglycemic drug of sitagliptin and metformin, and that too not in a very high dose. Sitagliptin, yes, 100 OD. And the patient is obese, but the urine ACR or the eGFR is not done in this patient. So why do we need to do that? Because if you look into the global prevalence, it's around 11%. And if you look into the rising prevalence, it is around 11 to 14% in each and every corner of the world. And if you look into the mortality, it is 1.2 million at present, and it's going to be 3 million by 2040. So this is the burden of CKD that we have. And what is more important for us, high prevalence of CKD amongst Indian individual, which is around 17.2%, and more than 2 lakh person is already undergoing dialysis. So not only any diabetic patient, but what we need to know is even hypertensive patient, patient having a CV event, patient having nephrotoxins, patient having a previous history of AKI, family history, ethnicity, typical few races, is very important to screen them at least annually, or when the patient comes to us at least for once. And the REVEAL CKD has shown that around 27,000 patients, that early diagnosis and intervention can slow the progression of this disease. With this graph itself, we can see that. So no treatment, we have our mortality, morbidity, and we'll leave this world by around 7 years. But with a delayed intervention, we can increase our lifespan by 2 years, and with an early intervention, at least by 4 years. So there lies the significant impact of early intervention and early screening. So this patient, going back to the same patient, if you look into the eGFR and the urine ACR, it's 55 and 60. And if you look at the risk stratification, it's high risk. So this patient is at a high risk. If you go with the conventional therapies, the intensive therapies of glycemic control, good cholesterol controls, and good hypertension control, even after that, we have some amount of residual risk. So we have to think beyond glucose. We have to think and start as early as possible in a patient of type 2 diabetes, and we need to protect the heart and the kidneys. So what do the guidelines say? This has been previously mentioned. We need to look into the diet, the lifestyle modification, the de-addiction, the obesity reduction, nutrition as well as physical activity. Along with that, we need to look into the EGFR and maintain the rest of the medications. So the bread and butter for us, the metformin, we have to reduce it to half if the EGFR is less than 45, and we have to stop if the EGFR is less than 30. Regarding SGLT2 inhibitor, anything EGFR above 20 can be used, and we can continue till the patient is on dialysis. We have GLP-1 receptor agonists, we have the DPP-4 inhibitor, of which teneligliptin and linagliptin need not be reduced, the dose need not be reduced in a patient of CKD. And we have insulin, which is also again the safest drug in a CKD or a DKD. Pioglitazones can be used till the patient has got some volume overload. Sulfonylurea should be used with caution, and alpha glucosidase inhibitors can also be used. Now, regarding the FLOW trial as well, it has been stopped prematurely because of the overwhelming result. The interim analysis says it has got an overwhelming result, and semaglutide once weekly injection has been approved now. Now, the CKD and albumin, if you go by the ADA guidelines, we have CKD with albuminuria and CKD without. If you have CKD with albuminuria, the drug of choice is SGLT2 inhibitor. And if the HbA1c is still over and above, you can add a GLP-1 receptor agonist if the patient has pocket-friendly money. Then if the patient is not having albuminuria, we can start on with an SGLT2 inhibitor or a GLP-1 receptor agonist, either or we can add if the HbA1c is still on the higher stance. So why do we use an SGLT2 inhibitor? We say it has got no such glycemic benefit, but if you look into the factors, few factors, we say it has got intermediate efficacy, not as efficacious as metformin, may not be as efficacious as a sulfonylurea, but it has got an intermediate efficacy, and it can reduce an HbA1c by 0.6 to 0.9% with an add-on to another drug, OHAs. And the other extra glycemic effect is that it reduces body weight. Even in an ideal weighing person, we can lose up to 1 kg, and in an obese person, we can lose up to 3 to 4 kgs. But it's the initial loss, later on after 6 months, it plateaus. We have a significant improvement in the blood pressures as well. Another point to note is this patient is obese, so a 30 kg per meter square is his BMI. So here also we have to know that a use of an SGLT2 inhibitor and a metformin can reduce around 2 kg of fat loss. It's mainly the fat loss, and we Indians, we have a 30% extra fat. So we are very good patients for SGLT2 inhibitor. Waist circumference also, we have a tremendous amount of waist circumference, we Indian Asians, and for that reason SGLT2 inhibitor is a very good drug for us as well. So it improves body fat patterning, especially the hepatic and the pancreatic fat. We have the evidence with the dapagliflozin. Now, when we talk about diabetes control, we always think about sustainability. So this is one of the drugs which is sustainable. So 208 weeks trials we have, and it has shown to maintain HbA1c, not only HbA1c, the weight control, even the blood pressure control, and most importantly, the hypoglycemia rate is 1/10 of what we get with the sulfonylurea. Now, I'll be talking about empagliflozin and dapagliflozin because these are the two drugs which are most commonly used in a DKD. So when we talk about empagliflozin, we have to talk about the EMPA kidney trial, which was done on around 6,600 patients, each being divided into two groups, one having EMPA, the other having a placebo. And what we saw was around 54% patient, the baseline population did not have diabetes, and 27% had a CV history, CV-related history. 35% patient had an EGFR of less than 30, and around 48% had a good amount of urine ACR, which is around less than 300. But the distribution of the kidney disease were actually equal. So 31% had diabetic kidney disease, and the rest were from hypertensive or the other glomerular nephritis, or causes unknown. But what we saw was a 32% relative risk reduction in all the kidney outcome, irrespective of the status of albuminuria and the EGFR, which was very important for us. Again, we had been talking about hyperkalemia. Here it was seen to have a reduction of 56% of edema and 52% hyperkalemia. There was a reduction in the numbers. So if you look into the summary of the EMPA kidney trial, what we saw was the primary composite outcome was reduced by 28%, which was actually significant. All-cause hospitalization was reduced by around 14%, which was again significant. Then we had hospitalization due to heart failure or CV death, which was nominally reduced but was not significant. And all-cause death was also nominally reduced but was not significant. When we look into the dapagliflozin, we have to talk about the canvas as well as the declared TIMI trial as well. If you look into the representation, this is what we get in our real world practice. So we get patients with multiple risk factors, not always patients with an event. So this is something which comes to us as a clinician. So when we give a drug, we need to look at its benefits in a patient with multiple risk factors so that we get a window of opportunity to prevent another event. So there was a better representation of the population that we get in the canvas and the declared TIMI trial. And if you look at this structure, first column is multiple risk factors, then the increasing risk of heart failure or CKD, then the first event, then recurrent event, and then the death. So we have a preventive place, that is the increasing risk of heart failure or the CKD, where we need to act, and the window of opportunity there. And the therapeutic window is obviously after the event has already occurred. So if you go to the through the eGFR that we have with declared canvas and EMPA-REG, we see that more or less eGFR was around 85, 74, and 76. But what we see is with the use of dapagliflozin, there was a slowing of the renal disease progression, which was by 47%. It was irrespective whether the patient had any event and or having multiple risk factors. It was irrespective of the eGFR status, and there was a delay in the progression and a regression as well with the use of dapagliflozin, which favored the use of dapagliflozin. So these are the dedicated trials that we have, the CKD outcome trials that we have, and the FLOW trial that has been already mentioned. So now the DAPA CKD trial, which was the first trial that we had in hand as an evidence, 4,300 patients were included, 1:1. It was divided. 25 to 75 was the eGFR, and most of them, more than 45 was around 41%, and less than 45 eGFR was around 59%. Here, it was a better representation in the sense that diabetic population were more amongst the CKD patients here. But if you look into the primary composite outcome, we see a 39% reduction, which compared to the EMPA kidney, it was around 28, and all-cause mortality was around 31%, and composite of CV death and heart failure was around 29%. But if you divide this into diabetic and non-diabetic population, you will see the difference. So it's not only diabetes. Patient with CKD, if the patient can tolerate, or if the eGFR is more than 20, we need to start on with an SGLT2 inhibitor, especially dapagliflozin, because of the evidence that we have here. So if we go with a head-to-head comparison, this cannot be made a head-to-head comparison because the population enrolled were not same. But still, if we look into the comparison, DAPA will obviously fare better than empagliflozin. So if you look into the chart in which we have pointed the drugs that we can use in a patient of CKD, obviously the first three are the flozins. So how do we say which patient is eligible for, a CKD patient is eligible for an SGLT2 inhibitor? First of all, eGFR has to be more than 20. A patient can have albuminuria, may have heart failure as well. These are the ideal patient in which an SGLT2 inhibitor has to be used. So this patient was put on a SGLT2 inhibitor, sitagliptin was avoided, and what we can say is possibly there will be some amount of improvement in the eGFR and the albuminuria. And we have to say this, CKD is a very big burden for us. CKD needs to be controlled very early in the start. We have to nip the bud at the very beginning, otherwise we are going to lose the battle. So diabetes, DKD being one of the major reasons of CKD, diabetic CKD needs to be treated. Diabetes CKD needs to be, diabetic kidney disease needs to be screened at the earliest annually, and we need to intervene very early so that we can prevent an event. And we have huge amount of data that SGLT2 should be used, SGLT2 inhibitor should be used in a patient with diabetic kidney disease. Thank you.
Ipshita, excellent presentation. Thank you. The floor is open for discussion. Any questions?
Is dapagliflozin effective in proteinuric and non-proteinuric diabetic kidney disease? Because 30-40% diabetic kidney disease is non-proteinuric.
Yes, sir. Sir, according to the guidelines, if the patient is diabetic kidney disease with an eGFR of more than 20, if proteinuria is present or not, we can start on with an SGLT2 inhibitor. So GLP-1 receptor agonist is another option in case of non-albuminuric DKD, but because SGLT2 inhibitor being pocket friendly for us, we prefer using SGLT2 inhibitor there as well.
We rule out other form of nephropathy
Absolutely,
in
sir.
non-proteinuric
Absolutely,
patient.
sir. Because, sir, as in my first few slides, I had mentioned that in diabetic kidney disease, in patients having CKD along with diabetes, in those patients around 86% are possibly due to DKD, but around another 14% is non-DKD patients. So diabetes history might be there, but CKD may not be due to diabetes. So we need to. Yes, that is one of the most important sign that usually DKD is associated with diabetic retinopathy. So my prototypical case that was seen here had diabetic retinopathy. So I made it sound or go that way.
So is it also effective in polycystic renal disease with proteinuria?
Sir, I think sir will be able to answer that because
See,
PKD, polycystic kidney
PKD,
disease
yes,
with SGLT2
because there are small group of trials which have shown the effectiveness, but actually the mechanism is more of genetic in ADPKD, and that is related to this. There are some channels which actually keeps pouring fluids inside the cyst, PKD1 and PKD2 genes. So there, the mechanism is mostly hypertension control, which has shown some advantage, but we don't have large scale data to support. Even in these trials, the number of PKD patients was, I think, 1% or something was the number of genetic related kidney disease. So that is my answer to this. But answering to the point which he just mentioned, that there is 30% patient, 20 to 30, 28% to be precise, of non-DKDs in DKDs. So how you are going to rule out? The rule out is first you have to see the pattern of change in GFR. If the natural progression of diabetic nephropathy is not occurring, you have RBCs in urine. Absence of retinopathy can still be there in 40% DKD patient. Apart from that, you have to see the kidney size, you have to see the urinary tract, you have to see the behavioral pattern of the creatinine and the GFR. If you have doubt, better do a biopsy and rule out non-diabetic kidney disease than keep on treating that patient as a DKD. So that probably is Ipshita, very nice presentation. I have only one question. In which patients you will avoid SGLT2 inhibitors?
Sir, obviously those patients with an eGFR of less than 20, I don't initiate, but if the patient has been put on an SGLT2 inhibitor, till the patient goes down to dialysis, I'll continue using an SGLT2 inhibitor. If the patient has got some anatomical defect which causes recurrent UTI, so there I have to stop using an SGLT2 inhibitor because I'll be taking the patient to the grave. This is one of them. And obviously in the initial phases where the patient is elderly, the patient might have a fluid issues, potassium issues in the initial few weeks, we need to monitor these patients. And obviously acute patient admitted in the hospital, we need to stop their SGLT2 inhibitor. Though there is a DARE trial which shows that DAPA is good in there also, but still I would suggest insulin is the best therapy when a patient has been admitted in hospitals.
Would you like to use SGLT inhibitors in patients having urinary structural abnormalities?
No, sir, that's the anatomical issues. If there is an anatomical issue, the chance of getting a recurrent UTI is very high, so I won't be using there.
So probably if evaluating a post-voidal residue in these patients before starting SGLT2 inhibitor is very important. Yes. And getting a baseline uroflowmetry to, because see, they will have also diabetic cystopathy in addition to that. So their bladder functions will not be normal. So getting a baseline uroflowmetry before starting always helps and makes your inertia better before starting SGLT2 inhibitor. One last question. What about using SGLT2 inhibitors in patients on CAPD having normal urine output?
Normal urine output.
Urine output patients on CAPD, PD, peritoneal dialysis. Have you any idea?
Sir, I won't be using, because dialysis in any form, I won't be using an SGLT2 inhibitor.
Because
That
they
is
have
my
some
take.
residual
Yes.
renal function, if I'm
And,
saying that they have normal urine
Even the
output.
CKD patient, they had been using in patient with on maintenance dialysis as well, but I would not use it in the real world practice. That is my take, because it becomes very erratic. Everything becomes very erratic. That's my take.
So, Ipshita, one very simple and naive question. I mean, in our practice, we find patients, diabetes with or without proteinuria, EGFR is okay. BP is on the lower side, but no, not with or without proteinuria, I'm sorry, with albuminuria, but EGFR is okay. So, for guideline based, we should put the patient on ARB and all, but the BP gets low. So will in that case the SGLT2 inhibitor be a better choice? And can
ma'am,
you,
the
my
patient
nephrologist colleague is also sitting, so can we avoid the ARB there and give importance to the SGLT2? Because many of the times we have to do that.
Yes.
So dictum tells that ACE or ARB is the drug of choice first for albuminuria, but with the advent of SGLT2, we find that that serves as a better purpose. This is a practical thing.
Yes,
I mean,
ma'am, I do give SGLT2 inhibitor because diabetic patients, we have a dictum nowadays that we should not start with a single drug.
Yeah.
We have to attack multiple
so now I'm comparing
pathophysiology.
with SGLT2 versus
Yes,
the ARB
ARB,
in terms
yes.
of albuminuria.
Many patient comes
so
to us with a
preferably
BP,
we
say
do
90,
give the
90 to
yeah.
100.
Yeah,
There
yeah.
I do not give an ARB
Yeah,
and I give
that
an
is a
SGLT2
practical thing which I
inhibitor.
wanted to
Yes,
highlight
yes.
because that is practice and that is not guideline based.
Yes.
Okay, thank you. So if there are no questions, we wind up the session. It was a wonderful session and wonderful job done by Ipshita.
Thank you, ma'am.
Thank you.
Thank you, chairpersons. Thank you, speaker ma'am. I would like to request you to kindly felicitate Dr. Ipshita Ghosh. I would like to invite Dr. M.L. Bansali sir to kindly felicitate Dr. Shupriya Datta ma'am. Thank you, chairpersons. Thank you, speaker ma'am. I would like